My topic for today is placenta. It's simple, but it has many hidden things inside. I'll just fly through its normal anatomy, embryological features, but my main emphasis would be on invasion of placenta, which is a dilemma to diagnose. I would like to share some features, sonographic feature, by which we will be almost definite to diagnose placenta accreta, encreta, or paracreta. Surely, I'm going to blend and flavor my talk with MRI because MRI has immense role for the diagnosis of invasion of placenta, that is accreta, encreta, or paracreta. As I said, placenta is simple, but it's interesting, sometimes ignored, and sometimes incompletely understood. We revolve around these things: embryological features, its size, shape, location, parenchymal changes, its function. Role of placenta, we know it's nutritive, respiratory, excretory function it has, and it also releases many hormones, which are helpful for the development of the fetus. As its name goes, it's flat, it's cake-like. A little bit embryological feature, both fetal and maternal components contribute to the structure of placenta. The villi, which is the main key of placenta, of the chorion frondosum are fetal in origin and contains arterial plexus supplied by umbilical artery, whereas the maternal portion of placenta is composed of decidua placentalis, which lines the intervillous space. Placenta, decidua has a very important role in anchoring the placenta, and its deficiency due to repeated cesarean and pregnancy leads to invasion of the placenta in some of the cases. This is how it goes. This part is the fetal, which contributes by umbilical vein and umbilical artery. This is called umbilical cord, and they divide into certain branches. And this part is myometrium, which is maternal part. Embryologically, as we were talking about decidua has three parts. That's capsularis, basalis, and parietalis. This is very important to know. Capsularis, you can remember by cap. Cap means it's covering the embryo. And parietalis, endometrium is lining the remaining of the uterus. And the basalis, which anchors the chorionic villi. This is important. If it is deficient, there is chance of invasion. We all know the appearance. On ultrasound, the placenta is homogeneous and slightly echogenic. By 10 weeks, it's quite echogenic, and proper villi formation after 10 to 12 weeks, and true maternal flow develops after 12 weeks. And intraplacental arteries are seen by 16 to 18 weeks. So this is best seen, early placenta is best seen on transvaginal scanning. We must be aware of the fact that placenta goes with the pregnancy. As pregnancy develops, the thickness of placenta goes parallel to that, meaning by placental thickness in millimeter corresponds to gestational age, especially in second trimester. Meaning by, if it's 20 weeks pregnancy, placenta would be around 20 millimeter thick at its center. If it is 30 weeks pregnancy, placenta would be around 30 millimeter at its center. So we have come to know normal placenta. Similarly, there are thin placenta as well as thicker placenta. Thin placenta are called the placental malacia, and there are certain diseases which leads to thin placenta, and these are systemic vascular diseases of mother, chromosomal anomalies, IUGR, marked polyhydramnios. And thick is very common as we come across. Thick means more than 4 centimeter, and this is called placentalomegaly. That means it could be due to fetal height drops, antepartum infections, maternal diabetes, and maternal anemia. So the significance of placenta is abnormalities of placenta are important to recognize owing to the potential for maternal and fetal morbidity and mortality. So what are pathological conditions of placenta, which includes placental causes of hemorrhage? My mainstay of my talk today is about hemorrhage, gestational trophoblastic disease, RPOCs, non-trophoblastic tumor like METs and cysts. As we know, the imaging modality for placenta is readily available and used by almost all of us, and this is sonography. So sonography remains the imaging modality of choice for evaluation of placenta. Yes, in some cases where there is doubt about the invasion, we need to have help from MRI. I'm talking about MRI because we are all doctors, some of us are phenologists, some are radiologists. We should know the role of MRI in placental invasion, because when there is invasion, life of not only the life of fetus, life of mother is at threat. So we should know very precisely what's going on. This is how a normal placenta look like. It's echogenic, it's homogeneous, and there is a small retropercental hypoechoic space which is called retropercental complex. That was the grayscale image, and we see on grayscale there is a hypoechoic complex which has immense importance in normal placenta and in pathological condition. And when we throw colors, normal, randomized, continuous flow, we see the retropercental area. When we know normal placenta, we must be aware of morphological variants. Variants include different shapes. One is bilobed, other is accentuated lobe, the third one is circumvallate, and fourth one is placenta membranacea. We must be aware about these placentae, because if we are not sure, we might have problem during delivery and after delivery also. This is how a accentuated lobe goes. There is a bigger lobe up here, see marker, and the smaller lobe, and these are connected by a thick membrane. Since nature is very kind, they have put umbilical cord on the bigger lobe, so the baby survives. We get good nourishment, but we have to identify the smaller lobe, because if we don't deliver smaller lobe, we're going to have postpartum hemorrhage. Similarly, there is a bilobe placenta. Here, there was a smaller one and the bigger one. Here, nature has divided into two almost equal parts, but the umbilical cord is inserted at the center where the membrane is. These placenta has to be diagnosed because these are again threat to postpartum hemorrhage. The third one is circumvallate placenta. In this placenta, the chorionic plate, the fetal surface of placenta, is smaller than the basal plate, the surface interfacing with the uterus, with the rolling and shouldering of placental margins. This we can identify. So that means the surface area is smaller as to a normal placenta in circumvallate placenta. The fourth variety of variant is placenta membranacea, which may present as a complete previa if it is low lying. Another variety, that is placenta velamentous insertion of the umbilical cord. That means the cord is not inserted to the proper site of placenta. It's either at the edge or close to the edge of placenta. So such babies are not going to get proper nourishment, and they might end up with IUGR and, of course, antepartum and postpartum hemorrhage also. So placental causes of antepartum hemorrhage are placental hematoma, abruption, previa, vasa previa, and our main topic, placenta accreta, increta, and paraccreta. We've been seeing a lot of hematomas daily here and there, and those are, sometimes they are retropercental, sometimes they are intraplacental. The key is to the identification based on clinical history. There is no era for the grayscale nowadays. It's all Doppler. So when you see something inside the placenta or outside the placenta, which is not normal, you need to have help from the doctor. If there is flow in that lesion or area, there are chances that that could be a normal uterine contraction or a fibroid. But if it is negating flow, there is no flow inside it, there are chances that there is a hemorrhage based on history. This is one of the examples. This is placenta, very nice flow all around, but we can see hypoepigrounded area inside the placenta, which is negating flow. So this is favoring an intraplacental hemorrhage or hematoma. Another variety is placental abruption. We see every day. This is placenta, and close to the posterior aspect of the placenta, there is hypoequic area, and which is likely to be a hematoma based on history again. Yet another example, there is a large hematoma lifting up the edge of placenta. If the separation or abruption is more than 40%, there is a serious threat to the fetus. Here we come. This is placenta accreta, increta, and paraccreta. So, how do we go for it? A defect in normal decidua basalis, as I told you. Decidua basalis is the key for anchoring of villi. So, if there is a normal defect in the normal decidua basalis from prior surgery and instrumentation, abnormal adherence or penetration of coronary villi to or into the uterine wall. So, it's going to be classified according to the depth of invasion. This is how it goes. The extents of adherence and invasion of placenta tissue varies. There are three types. One is placenta accreta, where there is a superficial invasion of the basalis layer. It's approximately seen in 75% of cases. The second is placenta increta. It goes into deeper layers and goes up to the myometrium. And the third one is paraccreta, even deeper invasion involving serosa or adjacent pelvic arteries. We'll see the examples. This is a schematic diagram. On the top, this is normal. We see normal retropercental complex and the placenta. The first type, accreta, that is just touching or going into the myometrium. The third one is increta. This has gone further into the myometrium. And the paraccreta is gone beyond the myometrium, beyond the serosa, and sometime into the other pelvic organs. What are the risk factors? 95% of women have identifiable risk factors, and they are placenta previa, one, prior cesarean delivery. If there are more than 2 cesarean sections, the percentage will be high from 30 to 40% and onward. Increasing parity, increasing maternal age, and prior uterine surgery. So these are the sonographic features which will lead us to the diagnosis of placenta previa, accreta, or increta. There are 5. 1, placenta previa. 2, prominent placental lacunae with turbulent flow. 3, abnormal color Doppler imaging. 4, loss of normal retropercental clear space, which we've seen in the start. And the 5th one is reduced myometrial thickness less than 1 millimeter. Now, how do we go for it? 1. So, placenta previa is the key. So, when there are number of cesarean section, curettage, or trauma in a different way to the myometrium, patient is going to have a chance of having a placenta previa. So, what is previa? It's abnormal implantation of placenta in the lower uterine segment overlying or near the internal cervical os. If it encroaches upon the cervical os, it is major or complete previa. If not, then minor or partial. Normally, the lower placenta edge should be at least 2 centimeters away from the margin of internal os. This is how it goes. On the top, on the left of my side, there is a low line. It's away from the internal os. Second is marginal, just reaching the internal os. Third is partial, it's just covering the internal os. And fourth is total, is totally covering the internal os, which is also called complete previa. One of the image, just reaching the internal os, placenta is marginal, just covering the internal, this is cervix, this is lower edge of placenta, is covering the os, this is incomplete or partial previa. And this one, day before yesterday, I just scanned, is complete. Some of part is up on the interior wall, and some of the part is low on the posterior wall. Do you find anything abnormal in the crowd? Yes, somebody is right. There is flow in the wall, and if you see a black structure here, that's the development of lacunae. This patient is at 22.5 weeks of gestation. It's very early. Lacunae develop as the progression of pregnancy goes on. So there is previa type 4 or complete previa, and with the suspicion of accreta. We need to have a follow-up. We have to give a caution to the gynecologist. Yes, I see a placenta which is low-lying, covering completely, and I see some flow in the wall of the unit bladder, and I see some black shadow here, which are probably lacunae. We'll talk about lacunae more. The same patient, complete previa, we can see lacunae here. This is again complete previa, completely covering the internal os. So, what is the pearl? Pearl for you. First pearl is placenta previa itself raises the risk for placenta accreta due to implantation over a highly vascular, poorly contractile lower uterine segment. Next is placental lacunae. This is the most important thing for the diagnosis of accreta. So what are lacunae? These are vascular structures of varying size and shape, create a moth-eaten, जिस तरह वो कीड़ा खाता है लकड़ी को, दीमक खाती है, so it's a moth-eaten appearance or a Swiss cheese appearance. Many of us must be fond of cheese. This is Swiss cheese appearance. It's different from normal vascular lakes, and it's more indistinct and low and show turbulent flow. This is the difference. Again, Doppler comes into play. In a normal lake, you see low level of smooth flow, but when it's a lacunae, it's high velocity and turbulent flow. It has highest sensitivity in the diagnosis of placenta accreta. So this is the main key for the diagnosing placenta accreta. This was a case last month, which was low-lying, covering the os. Then we can see black holes. What are these black holes? Black shadows. Do you see normally in placenta black shadows? Are these such areas, hypoaquic areas? So these are lacunae. You see number of lacunae. They are shapeless, they are randomly placed, and when we turn on Doppler, we see turbulent flow in them. So it has very high sensitivity. When you see previa, when you see lacunae, there is a high sensitivity of being invaded by the villi into the myometrium or the subtle form of accreta. So this is the main key. And by the way, this case was operated and it turned out to be accreta. So it was diagnosed like on the 24th of April, and this has been operated upon with accreta. This is a similar example. Again, we see hypoaquic areas scattered, randomly placed, but show flow. Normally, you don't find such lacunae in a normal placenta. So yet another example of lacunae. So what is the pearl? Pearl is the presence of prominent placental lacunae has the highest positive predictive value for being a placenta accreta. So be very vigilant. When you see a normal placenta, you have image. But when you see low-lying with hypoaquic areas, don't mix them with vascular normal lakes. Try to see a Doppler flow in them. Next, abnormal color pattern. Color Doppler signs suggestive of placenta accreta are dilated vascular channel with diffuse lacunar flow, just we talked, irregular vascular lakes with focal lacunar flow, hypervascularity linking placenta to bladder. We'll see in coming slides. That's another good sign to diagnose placenta accreta or increta. And of course, dilated vascular channels with pulsatile venous flow over cervix. This is one of example. We just had a look on lacunae. We just saw in the center there are lacunae. randomly placed, shapeless. So the fourth one is loss of retropercental space. A retropercental hypoechoic usually seen with normal presentation also. So this is not a very strong predictor for accreta. You might see normally reduced retropercental space, which can be up to 1 centimeter, which can be up to 5 millimeter. So that's not a strong predictor. So this is one of the example of accreta. There is loss of normal retropercental space, prominent lacunae, highest positive predictive value, and we can see increased vascularity at interface of uterus and bladder. So now we are confident. We are dealing with probably an accreta. This is another example. Number of lacunae, loss of retropercental space, low-lying placenta, accreta. And the next variety is more severe form is increta. We can see in this image multiple placenta dilated vessel extending from placenta through myometrium. So we'll call this Swiss cheese appearance. Turn on Doppler. There's a flow again. Flow in the placenta, flow in the wall of the unibladder. And the third form is placenta percreta. It's very difficult to diagnose. There is protrusion of placental tissue beyond the outer confines of the uterine myometrium. We'll see the increased vascularity. So we can see 1, previa. Number 2, loss of retropercental space. Number 3, lacunae. Number of lacunae. So these 3 signs we can see even on a grayscale image. So when we turn on the Doppler, what happens? This happens. Immense hypervascularity. So it has gone to the wall of the unibladder, even beyond the wall of unibladder, going up to the interior lower abdominal wall. So this is the case of percreta. Done. So there are 4 pearls to diagnose accreta. Loss of retropercental space, previa, lacunae, and number 4 is increased vascularity. I'll just touch MRI because all of us must be aware of its significance. We have specific fast acquisition for MRI. There is a demonstration of uterine bulging and loss of normal uterine contour in MRI. MRI provides precise anatomical images, must be recommended in patients with potential life risk during surgical intervention. So in MRI, we see placenta previa, uterine bulging, heterogeneous signal intensity within the placenta, lacunae, dark interplacental band on T1, T2 weighted images, focal interruption in the myometrial wall, and tenting of bladder. This is a very good sign. I'll just demonstrate. And direct visualization and invasion of pelvic structure by placental tissue. We just saw in one of the examples of percreta. Vessels were going into the wall. These are the image of MRI. I hope you will, I would like to share good things with you. You will learn a bit with me also. This is normal. This band is placenta. It's going up, down. This is cervix. It's completely covering, and here it finishes. So, are you with me? So, this is complete previa, and this white structure is urinary bladder, which has smooth walls. Coming here, this is example of accreta. You see the smooth walls of urinary bladder are gone. They are being indented by the placenta. So there is invasion. Similarly, the interface between internal os and placenta is gone because it's invading the upper cervical region. So this is how we very nicely see the invasion by MRI. One more example, similarly. If you see, there is indentation of urinary bladder again, which we cannot see very precisely on ultrasound. So this indentation and internal hypointense area leads to the diagnosis of some invasion to the placenta to the other structures. Yet another example, there is invasion in the interior myometrial wall, which is thinned out, and there are vessels. Similar, there is thinning of myometrial wall and invasion. So MRI has very high sensitivity to diagnose placenta invasion for especially for increta or percreta. just to touch gestational trophoblastic disease, and we have hydatidiform molds, invasive molds, and choriocarcinomas. We do diagnose every day and night, and this is one of the example of complete mold. We don't see fetal ball. And similarly, there are vesicle. You can very confidently label it as a molar pregnancy. This is a partial mole. We see part of this fetus here, and the rest is again heterogeneous with small cystic areas. And this is one of the examples of invasive mole. This has gone beyond the normal limits of myometrium. It has invaded into the myometrium, and when we turn on the Doppler, we see fluid flow into it. So your role as a sonologist and radiologist is very important to give a roadmap to the gynecologist that what we are seeing, what we are talking about, and what we are sharing with you to decide a plan for surgery and other things. RPOCs we see daily, and when patients bleeding with RPOCs, there you find vessel feeding to them. We can demonstrate. And sometimes you find chorioangiomas, these are round masses, and these can be vascular also. Sometimes a little bit of cyst. And this brings the end of my talk. My main aim was to bring you some good points to diagnose invasion, like acrita, paracrita, and incrita. So take-home messages. Although uncommon, abnormality of placenta are important to recognize owing to the potential for maternal and fetal morbidity and mortality. Sonography remains the dominant imaging modality for evaluation of placenta, and MRI imaging is useful for further evaluation when increased tissue characterization is valued. Particularly invasive placenta process, that is placenta acrita and gestational trophoblastic disease.